and this kind of gets a little bit about your question, your comment, they've gone so far as to be the first state to actually, they're in the process of getting the hunger vital sign to be part of their state's Medicaid performance metrics. So if you are receiving Medicaid dollars as a health provider in the state of Oregon, you have to ask these 2 questions as part of your performance measure. Something that they're currently in the process of making happen. It would be the first social determinant of health performance measure in the state of Oregon. And other states are going in that direction, Ohio and Massachusetts as well. I mentioned earlier that we're based also, one of our research sites is at Hennepin County Medical Center in Minneapolis. And our principal investigator there has partnered with Second Harvest Heartland. And so they are screening in the pediatric department. And when a child screens positive for food insecurity, there is an electronic referral that is made to Second Harvest Heartland. And they follow up with the patient and help them apply for SNAP. They provide emergency food assistance. And there's also an on-site food shelf as well. Kaiser Permanente, a very similar model in Colorado. So they're using it not just in their pediatric department, but they're using it in their geriatric department, their diabetic clinic, their family health centers. And they are asking the 2 questions. This is just, they also have great data. This is their monthly referrals to HungerFree Colorado. So they also have a business agreement with HungerFree Colorado. So they make, the pediatrician does the screen, and then when they're screening positive, that electronic referral gets shot over to HungerFree Colorado, and they do the outreach, the follow-up. And when they started, what they did was they just provided a pamphlet and said, here are the places that you can go. Here's your local food bank. Here's where the WIC office is located. Here's where you can go and apply for SNAP. And about 2.5 connection rate from that. And then once they had that electronic agreement and that sort of fax got sent over to HungerFree Colorado, it skyrocketed to 33%. So you really want to have that warm handoff. Like I said earlier, that doing something is better than doing nothing. And if all you can do is screen and your intervention is here, is a list of resources, there's nothing wrong with doing that. But the more robust you can make this intervention, the better the outcomes are going to be. And so those are a few examples, and there are others. And on our website, we have listed this sort of national repository of agencies, health centers that are using this tool, and it's sort of a way to connect and share best practices if you want to start doing this, if you're already doing it. But I just want to talk a little bit about the policy implications of this. So we have what's called the triple aim of healthcare, and it's really where healthcare in America is going. So we want to lower costs and improve patient care and improve health at a population level. That's what the ACOs are hoping to achieve, and that's what the ACA was really designed to do in many ways. So this is the goal, and this is really public health minded. But historically, what do we actually do? And this is a great book. I don't know if anybody's read this by Liz Bradley and Lauren Taylor. It's called American Healthcare Paradox. And basically their argument is if you look at spending on healthcare, the United States spends far and away the most on healthcare out of all the industrialized nations. And on the surface, that looks like a good thing. We're spending a lot on healthcare, so we should get good results. But when you look at these results compared to the other 34 OECD nations, we rank 25th in terms of maternal mortality. We're 26th with life expectancy. Low birth weight is 28th. And with infant mortality, we're 31st. And these are like just numbers, and it can get a little sterile. But when we say infant mortality, what we're talking about are dead babies. That's what it is. We're 31st. And so Lauren and Liz, they looked at, well, what about the rate of social spending? What are we spending on SNAP and WIC and other sort of housing and energy supports? And the U.S. does a little bit better, or almost as much as Estonia. We're not doing too well compared to other nations. And so when you put those together, you see that while we spend by far the most on healthcare, we're not really spending a lot on social services and social infrastructure, and so we're really in the middle of the pack, and that's why we're seeing those outcomes. And so, are there solutions to this? There are. So, there are efforts to bring this screening tool, the Hunger Vital Sign, and others for housing and energy and medical trade-offs to a place of national use and adoption. It's just happening as we speak. So Center for Medicare and Medicaid Studies, they are conducting a project called Accountable Health Communities, basically, where they are accepting applications for health centers, hospitals to take 3 different approaches: screening for needs and providing information about resources, screening and navigating into those resources, and then sort of the more robust version, which is screening and aligning the healthcare system and community organizations. This is a project that is just getting started. It's going to have a 5-year evaluation beginning in 2017. So that is coming down the road, but what about right now? So I'm sure a lot of you are familiar with community benefit dollars and community health needs assessments that hospitals are required to do. Are you all familiar with that? Or okay. So basically, to maintain their nonprofit status, hospitals have to show that they are providing some sort of community benefit. Before the ACA, they would provide charity care, and that was how they would maintain that 501c3 nonprofit status. But now that insurance rates are going up, which is great, there still needs to be some sort of adequate community benefit that's happening there. And so part of the things that can count towards a community needs assessment and a community health improvement plan are ensuring adequate nutrition. And so hospitals are identifying housing and nutrition and obesity as some of the issues that they're seeing in their community through that needs assessment, and are including it in their community health improvement plan. And these are publicly available. You can ask your local hospital for a copy. And I think this is a great way to really partner with healthcare organizations and hospitals. You can review that plan, and if you see that nutrition and hunger, obesity are issues that they've identified, you can approach them, and I think that's where the partnership can begin. That's one way to establish that partnership. Those are the slides that I prepared, but I really would like to answer questions you have and just get a conversation started.
So how do you calculate the financial benefit to a hospital or their obligation to provide that community care under that IRS Act to maintain their 501c3? So how do you determine what their annual budget is that they have to spend on community development like that?
Right. I don't know exactly what the dollar value of it is.
There is no dollar value.
No.
I mean, they have to prove, I used to work for the Children's Hospital of Vermont, so we have to prove that we were doing charity care. But our hospital could do X percent and this hospital could do X percent. There's really no cap, or, I mean, obviously they have to show that they're doing something.
Yeah, it's kind of considered a black box in terms of what goes into it, and also how do you access those dollars as a community agency. It's still sort of being fleshed out.
Just have a question about the 2 questions, and thinking about, I was part of another workshop about this, and there were a couple of organizations that were trying to sort of promote asking these questions in a way that it was really casual and conversational, as the first person who's sitting down and asking you how you're doing, and so that it doesn't seem like a question that I put my wall up and say, I'm not going to answer that question because then they're going to take my kids away from me. Or, if I say that this is an issue, what are the consequences for me? And so is there conversation happening around that, and who's been most successful in sort of integrating it into a conversation but still getting the results?
Right, that's a great question. So, having 2 questions, it's very simple in idea, but in implementation and actual practice, it can get kind of messy. And so there are, sort of 2 ways that you can do it. One is you can do it in person, one-on-one, and another way is you can do it in a written form, sort of, when you're waiting to see the doctor, you can, fill out these questions. And we've seen both work. We've maybe seen a little bit more success with the written kind of thing because it's a little bit more, private. But when you're asking these questions in person, whoever is asking these questions, whether it's a community health worker or a nurse or an actual physician, there needs to be the sort of, social intelligence and ability and training to actually connect with the patient as a person. And I think what we've seen as the most successful are physicians and nurses who develop a rapport. They don't just jump right into it. So it's part of sort of building that social history of the patient. And I spoke to one pediatrician in DC who deals a lot with adolescent medicine and kids with obesity. And to sit there in the office with a parent and a young teenager or an older teenager and say, asking these two questions, one of the things that parents do is they shield their children from hunger and food insecurity. And so to ask that question right there with a kid, they're just going to put their wall up and it's not going to work. And so, he'll use acronyms like, is your SNAP benefit enough? And, maybe the teenager, adolescent doesn't, really, know what that means. And so he'll use his rapport building skills and kind of sort of build up to those questions. Yeah. And that's also an issue that providers themselves kind of face is, okay, I can ask these questions, but is it my responsibility to do anything after that? And what do I do? How can I, I want to do something with this information. I don't want to just collect it and do nothing. And that's where I think all of you come in, and that's where the intervention happens, and that's why that's so important. So to have a strong, robust intervention is really important to making this work.
When you were, I'm sorry to go back to this, but it went so fast. When you were talking about making referrals to services, it needs to be more than a booklet. You used a term that I wanted to capture, and I didn't write it down. Do you remember what that term was? The way of doing things? You used a term.
Oh, when I was talking about the e-referral, the electronic referral that takes place between...
You were saying it needs to be more than a booklet, and you said this is a type of interaction.
Like a more robust...
Warm handoff.
Like a warm interaction, like a warm handoff.
A warm handoff.
Warm handoff.
Okay, yeah. Yeah, so... and what I mean by warm handoff is really not just here's a piece of paper. It's... Okay.
Oh, yeah, I understand the concept. No,
Right. No, I know. A good example of that actually is right here in Vermont at UVM Children's Hospital. It's being used in their inpatient pediatric department, and whenever a kid is being seen and they screen positive, there's that e-referral that happens, and it goes right to social work. And so then the social worker, while the child is still in the hospital, can sign the family up for SNAP or WIC and do a lot right then and there, rather than have them schlep on over to, Department of Social Services or wherever it is that they have to go.
This is what we're doing with Help Me Grow at 211. When someone calls and speaks to the child development specialist at 211, they get that kind of warm handoff.
Mm-hmm.
So that's why I wanted to capture that.
Yeah, and I talked earlier about the stress that's involved in not just poverty and food insecurity, which is a symptom of it. The level of stress involved, it really requires that. And that's why when Kaiser Permanente were just giving out the pamphlets, they didn't really see a lot of successes because, okay, I got this paper, but I've got a million other worries to worry about. But if somebody makes effort and reaches out to you and helps you through that, then you're going to have better results. I'm going to go over here and then over there. Faye.
I just wanted to add on from what you're saying about what's happening at UVM Medical Center with pediatric inpatients, is that kind of handoff, the warm handoff to a social worker, is something that can happen at any healthcare provider who has access to a community health team. That's something that they're there for, and HungerFree Vermont has worked in the past to help train all the social workers on how to help with the Free Squares Vermont application and different food resources. So that kind of referral that goes beyond the same handout is really available to a lot of different healthcare providers around the state.
Yeah, and that's so important to have that.
Is there a problem, the connection with all the hospitals? They have their own social workers, but is there a sort of a HIPAA problem if you could connect to a local food shelf, or you talked about examples of where that happened? It's great.
Yeah, that's a great question. So what about privacy and HIPAA requirements? So the way that it's working with Hennepin County and Second Harvest and HungerFree Colorado and Kaiser Permanente is the information that's being transferred, it doesn't quite trigger those HIPAA regulations. It's not enough information to really risk patient private information. And so that's how they kind of get around that.
So what is it? I mean, do you know, like?
I don't know specifically, but
they've been able to figure it out.
yeah, Dr. Sandy Stenmark is the one as the pediatrician in Colorado that's doing that work. And so I'd be happy to make that connection and get the answer for you. There's a question over here. Oh, okay.
First off, this is a topic that's near and dear to my heart just because I work at a farm at BYCC and we're partnered with Vermont hospitals throughout the state, soon to be, and donate CSA shares over a course of 12 weeks to Vermont families that answer similar questions. But I am more concerned about out-of-state because Vermont seems to have a really great community with doctors, staff, that is just so invested in making it work. And it takes a lot on the hospital's behalf and the patient's behalf also to be open to that. And how would you move this into a different state? Like how in Boston are you getting doctors to be on board to not just write a prescription and then say, yep, go to the food shelf for once every 6 months? How do you have people writing recipes or following up with patients or informing them of pickup times, or like how do you elicit that response from physicians all the way down?
That's a great question. So yeah, how do you get that buy-in? It really takes a champion and a leader in the hospital to say this is important, not to me, but to all of the patients, and this is what we're going to do. That's one way it happens, but that's incremental change. It happens hospital by hospital, health center by health center. It's great if advocates go and say, look, this is an issue and really you're a big player and you need to address it. That certainly helps to add fuel to the fire. Also, one thing is to have it sort of come top down with policy recommendations. The American Academy of Pediatrics, which really sort of drives a lot of the policy guidance for pediatricians in the United States, they released a statement in October of this past year urging all pediatricians to use these two questions in patients' annual well visits. And since that recommendation came out, it's caught on like wildfire. And so one of the things that we're working on is approaching other association groups like the American Academy of Family Physicians and obstetrics and gynecology and endocrinology and geriatrics and all of these groups and saying, look, social determinants of health is real and it's happening and we need to address it and here's a tool that you can use. And it really, we're talking about hunger here today, but it goes beyond that. It's housing, it's energy, it's medical trade-offs, and they're all interrelated.
And then that follow-up, like how, I guess just that follow-up piece, because you can give someone SNAP, but if there isn't, I don't know if you see that as a trend.
The follow-up, I mean,
with like physicians or hospital follow-ups with patients that are prescribed or referred for
right.
services.
So I mean, that's where technology comes into play, and electronic medical records are, sort of the way that things are going. And I don't know if anybody here is with sort of in the healthcare sector and uses electronic medical records. Epic is sort of the largest one. They just put this into their system, so it's part of their stock build. It originally wasn't. Now, whenever a new provider signs on to Epic, it's right in there. And when they release their next update, for those that already use Epic, it's going to be there. And so that is a way for physicians to then follow up, say, last time you were here, this was in your medical record, how are things going? They'll ask those two questions again. When it comes to prescribing the sort of food pharmacy approach and prescribing the access to the on-site food pantry, that's also part of the medical record, at least at Boston Medical Center. So the next time the patient comes back, say, oh, I can see that you accessed this, or I can see that you didn't go. Why not? How's it going? And so, using technology as a tool to, help with that follow-up and uptake and making sure that it actually gets from point A to point B is really important.
just a comment on that. I think something that we're seeing as a trend is the community health worker and the health coach. So I have a lot of hope in not putting all the eggs in the basket of the provider, because as much as I'm sure they want to do it, their capacity is really small. One of the things that we're excited about is we're having a chronic disease workshop at the Upper Valley Haven in White River. And so they'll be coming. It's a train-the-trainer program. But the cool thing is, for our shelter guests that actually access the main hospital, they have free health coaching. So they're going to take a 6-week course, but then from then on out, whatever their needs are, they can access that health coach. So I think more and more we're going to need, the community and people who are trained that may not have the specialty, but they have, the best practices and they're equipped
Yes.
with things that.
Yeah, and that's the key. That's where it really takes off and we see the most success. And in Colorado, they're doing that. So it's not just that the e-referral takes place, but it goes to the community health worker first, that navigator, whatever you want to call it. And HungerFree Colorado, if they make that outreach, but the phone has been disconnected or something like that, then they'll go back out, and that's the community health worker. That's the point of contact in the hospital, because the physician is, as you said, overburdened and is just on the verge of burnout. And so you have that person there that can help make the connection and really follow through. So that is the most successful way to do it.
I was just going to put a human Vermont face on those two comments, because the Academy of Pediatrics, one of the board members is a Vermont pediatrician, and when my 12-year-old daughter had an undiagnosed problem, he referred her to the community health team, who gave her a nutritionist, who went to a health food store, who so she was able to point at whatever she wanted to taste, and it was a way to educate her. Turned out it wasn't nutrition related, it was migraines. But the point is, I think these concepts are taking hold, and I think pediatric providers may be first up in this.
I think there's also that Vermont is working right now to integrate electronic medical records, because there's a lot of different systems being used in the state. So my program does use one of those databases, and so trying to integrate them, and we have a learning collaborative going along around the state trying to integrate multiple service providers together. And so in my program I work with elders, and we ask the similar questions, just 2 or 3 questions to everybody that comes in, and we ask it every year, so that we have a program with the Foodbank to increase food distribution through that. So we're working on it, and I think the state is making a little headway.
Yeah, it's pretty, it can be disjointed, and one thing that I didn't really touch on but is important to note is that it's a lot easier for larger institutions, inpatient centers, to do this than it is for outpatient providers, and that's just because the resources are there, and they have those community health workers and those navigators that some small outpatient providers might not have. I talked to somebody, a doctor in Jackson, Mississippi, and the idea of screening, she bought into it, but there was nothing that she could do. She felt like there was nothing that she could do. There were no resources, no time. It just, was just insurmountable. And so I think, everyone's at a different point, but I think it's great that Vermont is doing, what more to sort of better integrate all these, systems. And actually, I also want to say real quick that the slides on the America's Healthcare Paradox. So that book came out a few years ago, and what the authors recently did, it was just published in the journal Health Affairs this week, was they did that for each state in the nation. So this is comparing the U.S. to the rest of the world, but they compared states, and they found that states that had a higher ratio of healthcare to social spending had better health outcomes. And if you look at this paper, you can see they kind of charted it and see where everybody falls on this line. And Vermont's actually doing really well. Vermont spends a lot on healthcare, but they also spend a lot on social services as well.
Can you speak to what the whole food pickup sites look like on site at these hospitals, if they function separately insurance-wise? You might not be able to speak to the insurance component, but give a few examples of what they look like.
Sure. I don't think insurance really comes into play whatsoever. It's just integrated into the way that business is run, and so, they will screen positive and then be referred to the on-site food pantry. They're, given direction to where that's located in the hospital, and currently, for those who work in healthcare and especially in hospitals, real estate is really hard to come by. And the on-site food pantry literally started out of Dr. Debbie Frank's closet in her office. And a lot of the issues are like cold storage and things that a lot of food banks know very well that hospitals don't. So there's a big learning curve and opportunity for partnership there. But they sort of direct them to where that's located. It's right there. They don't have to drive a car to get there. And there's somebody who staffs it, and they tailor that meal to their medical needs. And it's just very sort of an easy way to do it. There's not a lot of complexity involved.
Could you touch on again what is included in kind of the question of are you receiving adequate nutrition? What that would kind of look like?
So that question, that's not part of the hunger battle sign. Are you receiving adequate?
Right, but
right.
Yeah, where that would fall to decide, if it was what you asked, that no one's going to say, or that often people don't, their idea of what they are eating is, as long as it's food, it's providing them nutrition.
Right. Yeah, that's interesting. So where does nutrition come into this whole screening issue? Yeah, this is I mean, the purpose of a screener is it's really to identify an at-risk population, not necessarily to diagnose. That's where the follow-up comes in. And so this is really to just identify, basic needs like, are you at risk of food insecurity, and then what kind of follow-up takes place. And I think that with the follow-up is where you get to, is it a nutritious diet? Is it an issue of, adequate nutrition? That's where the USDA, that 18 question screener does get a little bit at the whole nutrition kind of healthful diet issue. Somebody else have a question?
So, I guess I'm trying to think of how this can go outside of the healthcare realm. So I'm from Maine and from Good Shepherd, and I'm part of the child hunger team there. And so trying to think of how do we connect these questions to school nurses or in senior centers where people are coming for day programming. How does this translate out of the healthcare world? Because I think a lot of what we've talked about already is kind of healthcare has that stigma of should I tell my doctor this, should I not? Who's the trusted person? So have you seen examples of that kind of moving outside of healthcare?
Right. No, I would love to see you do that though.
Awesome.
Perfect. It's a huge opportunity. Like I said, this was validated in 2010. It's been 6 years.
Yeah.
It's really gotten its foothold in healthcare. But, I mean, every nurse in every school should be asking these questions as well.
Yeah.
Senior centers should be asking these questions. It's not just for the healthcare realm. Anywhere where there's an interaction with a vulnerable population, yeah.
So, just to kind of follow up on that, I work with a homeless agency that works with homeless families, that has started under the new program. It's a state initiative that also looks at family health and wellness. And that's kind of where I see this headed. We address child wellness visits, but are we really asking the questions that we need to be asking? And I think this is something that we can be targeted, which is why we came here today, which is cool. And how we can utilize the partnerships that we already have with the Vermont Department of Health and the other health agencies that we're working with to make sure that we're making appropriate referrals and making sure that our families that we're working with who are homeless are getting the best health and wellness that we can offer them.
Yeah, and I mean, there are others. So this whole CMS, Accountable Health Committees, they're not just looking at food issues. They're also looking at housing and other social determinants. And one thing, I think one of the reasons why this has been successful is because there is an intervention. Food banks exist. USDA has a huge. I mean, the United States has a very robust nutrition assistance cadre program, SNAP, WIC. And so there are interventions there. But when it comes to housing, that is really difficult. I know, at least in Massachusetts, and I'm sure it's the same in Vermont, you know, you might screen positive on a housing insecurity questionnaire, but what do you do then?
Yeah.
Join this wait list, and in 10 years, maybe you'll get a subsidized unit. So that is, you know, an issue, and it's something that I know a lot of people are working on.
I just want to go back and address your question
Yeah.
briefly. So the next session, we're talking about this in terms of how it's being implemented in Vermont, right next door. So this is a great primer to the conversation. But just to share that, so we've taken the 2-question screen and expanded it into these algorithms that are tools for service providers. And we have one that's targeted for social workers and non-healthcare professionals. And those include more about what kind of conversational topics we could bring up to, you know, kind of the language to use in a non-clinical setting. But there's a lot more to be done in that area. I think we've kind of started developing some tools. But I do know from the folks that we have been able to share that with, especially people who are working with seniors, that the non-clinical setting is really helpful, and the kinds of questions like, so you have this prescription and it says you have to take this medicine with food, you know, how's that going? And those can really get at it too. So there's a little bit of that happening.
That you have that,
Yeah,
that people can access on the website?
Yep, we have copies of it next door, and we do have it on our website. So
Yeah, and that, I mean, what HungerFree Vermont is doing is such a critical link here, because it's making the connection between healthcare and community agencies that needs to happen, and providing that sort of training and assistance and understanding on how to make this actually work.
I just wanted to speak to the school nurse piece, because I really like that holistic way of looking at public health, and the schools really are an ideal place to implement things like that. However, much like primary care providers in the office setting, they really don't have the capacity to set that referral piece in motion, because they're underfunded and overtaxed. And so what would be really neat is if an insurance company, which to my mind is currently, most of them are currently profiting quite nicely off of our ill health, might potentially utilize that same community funding money or blueprint money or whatever it's called when it's an insurance company, for example, and to shore up these on-the-ground mechanisms. So if an insurance company, say, funded a school health clinic, because what I'm seeing in the Northeast Kingdom is that more and more schools are not even employing school nurses. They're very, very difficult to recruit because the pay, the compensation is so diminished in terms of what you might make in a hospital. And even when they are recruited, they are working maybe 1 day a week, and that is barely enough time to really get your teeth into a population health. Or really what they're doing is running a practice in a school. So they're operating with a degree of autonomy. But if they do not have that support system in place to make those referrals happen, then it is very little point of even asking those questions. So that, I just wanted to point that out, that if you ask the questions, then what are you going to, like you said, what are you going to do with that information if you don't have that robust support system and referral system in place?
Yeah, I mean, you want to be able to have some sort of intervention, but I will push back and say, if there's nothing that you can do, at least collect data. If you have data, then you can say, look, the prevalence of food insecurity in this elementary school is off the charts. It's way higher than it is nationally. It's way higher than it is in this state. You know, here's a population that needs assistance. So if you have the data,
I would say that our systems are so, like, on the rickety brink of collapsing upon themselves, that for school nurses to collect that data when it's already collected as a percentage of free or reduced or their directly certified population, that wouldn't probably be the best use of their time if they're only there for 4 hours a week.
yeah, and I mean, that's an issue that healthcare providers face as well, because they have a ton of screeners that, you know, developmental screeners and all kinds of things that they're, you know, sort of, you know, having to ask. And so, I mean, it becomes a matter of priorities. What are your priorities, and where do you place your resources?
I guess I also push back on, like, I know that everybody is completely strapped for time, and with 4 hours a week with 5 schools that you might be working with. But if there's you guys in Vermont have the backpack program, so if that becomes, you have a referral in the school, and now you know that that kid is getting a backpack. In Maine, we also have our school pantry program. So even if it's collecting data and saying, here's a school that would be a great target for a new program, it might not be that you're connecting it to a community organization, but that there might be other ways to bring that in, I guess. I don't know. I'm still playing with it. It's in my head. Okay.
Any other questions?
Someone at lunchtime said to me over the table, I wonder what they're going to do with the leftover food from our conference. And that's got me thinking, because I haven't left my mind, that hospitals that I know have cafeterias. And I'm sure they don't always use up all their food every day. I don't know what they do with it. But have any of the hospitals that have food shelves within their hospital consider giving the family a voucher for a meal at the cafeteria?
Yes. So 2 hospitals that, it's Arkansas Children's Hospital in Little Rock and Hennepin County in Minneapolis, 2 of our research sites. There are 2 of the small but growing hospitals that are participating in the summer food service program. And this is a way that kids can get free meals, totally funded through USDA, at the hospital as a summer food service site. And what about adults? What about their parents who are also there? That's where sort of Arkansas, what they're doing is they're providing a voucher for a free meal in the cafeteria, so that it's not just the kid who eats, it's also the parent. And siblings as well, they're part of that summer feeding site. So it's something that hospitals can take advantage of, just not that many have yet.
I would say we've always done that.
Really?
People just don't know about it.
Yeah, and see that I had a slide earlier about connecting these islands of success. I think there is a lot happening out there, and there are hundreds, maybe even I'd say thousands of organizations that are using the Hunger Battle Sign and doing really great work that we don't even know about. And I think having a name for it, like the Hunger Battle Sign, is a way that we can get behind something that has some branding and recognition, and can bring attention to all the really great work that's happening. So yeah, there's a lot going on that we don't even know about.
Thank you. I think it's past 2 o'clock.
Thank you so much.